may be interested in testifying in Langdale down in.
Okay.
They use a percentage of Medicare now, and they have problems with balance billing for their patients. So they may want to come in. Good morning. How are you?
Okay. Apologize for being late. Um, if there are any legislators who are sitting out there in the audience, if you'd like to come up front, you're welcome to, so you can see and hear what's going on. This is the second meeting that we're having as it relates to balance billing or surprise bills. I've been having a lot of discussions with a lot of folks about this. I was talking to Derek Norton yesterday, and he says he's been really busy for the last 5 or 6 days talking to people who are part of his specialist team and all like that. My problem is I've been working on this thing for almost 3 years. I think at times it gives me a headache. I don't have a dog in this fight. I don't sell insurance, and I'm not a doctor. Only thing I'm trying to do is get the patient out of the mix as far as these surprise bills that come along after the patient gets out of the hospital. Before we get started, I'm asked Ms. Taylor if she will, what's your number there? 22. If she will open us with a word of prayer.
Thank you, Mr. Chairman. If you'd bow your head. Good morning, Heavenly Father. Thank you for the blessings of the day you've given us. Please bestow upon us the wisdom and knowledge to do what is right for the people, keeping you in mind. We ask these things in Christ's name. Amen.
Okay. To begin with, just a little housekeeping stuff. This is being live streamed, so anybody from anywhere can watch it while we're in process. It's also being taped, so that if somebody doesn't get to see it today, they can pull it up in 6 months and watch it. We've encouraged all the legislators in the House to keep an eye and watch this today, so that they'll be more knowledgeable of what's going on as it relates to surprise billing or balance billing. One of the things I'd like to start off with is, and I probably said this the last time because I have a hard time sometimes remembering what I have and have not said, so I'll just say it all over again. We've got a serious problem here, and I think I know of one legislator who's in the medical profession who agrees that we've got an issue here that needs to be resolved. But when you've got a patient, and I'm talking about for a planned procedure, I'm talking about such things as a knee replacement, shoulder surgery, stents, whatever's planned that you have to go to the hospital for in advance and get pre-admission and talk to the lady about your insurance card and all this kind of stuff. But when that individual goes to the hospital, they're under the assumption, and we all know what that does, they're under the assumption that the hospital and everything that part of this procedure will be covered by their insurance because they know their doctor is, their primary doctor who's doing the surgery or whatever procedure's occurring. They know the hospital is because the hospital takes their insurance card. And that's where the process kind of breaks down from that point on. Unfortunately, couple of things. I think in the medical profession, that is probably maybe the only or one of the very few professions that when you go in to have a procedure done or get some kind of work done or whatever, is the only one that you don't know what the price is. When you leave your pre-admission, you have no clue what that procedure is going to cost. You have no clue on who is or who is not in your network based on who's going to be part of the procedure. So that's what this bill is trying to do. Number one, and we're going to listen to some folks, and I want everybody to be very clear on what they're saying, and don't hold any punches. We want to hear what you're saying. And to give you an example so that you'll know what I'm talking about, and Jet and I have talked about this before. Last time when I was riding home, I talked to him most of my way from here to Columbus. The group in the hospital that I get the most complaints about are anesthesiologists, patients getting surprise bills. Now, I'm not picking on anesthesiologists. I'm just telling you how I want this committee to operate so we know where we're going and what the process is. I want you to be very honest on this thing because we got to get this issue solved. It's the number one reason that everybody who's sitting up here, that your constituents declare bankruptcy every year. Number one reason. So that is an issue for our constituents. And if you look at all the data, it says, 2 out of every 3 people in the next couple of years will get a surprise bill. I was hoping another legislator was going to be here. He's received 4 for $60-something each. He's paid them, but the collection aid or the company that the business or the hospital had issuing the bill kept sending to the bill and then started turning him over to collection agency. Well, not only did he have to pay the bill, now it messed up his credit. So, and that's happened to a state legislator. Might have been a good thing he wasn't here. Might have been upset. But we have issues like that we've got to get resolved. Now that was a billing error. I understand that, but that's something we got to get that resolved. But when a patient goes into the hospital, now here again, I want to emphasize this, what we're talking about today is transparency, and what we're talking about is when the patient goes into a hospital for a procedure that they're planning, is pre-planned. I think they need to know what the procedure's total cost is going to be. It needs to be broken down by what each individual provider is charging, if that provider is or is not in network. And I'll make another little statement to you wherever the Georgia Hospital Association is. I think, how many times will it take for a patient to say, well, this provider here is not in my network. It looks like I'm going to have to pay $500, $1,500. I had a guy tell me this past December in Columbus he had a $15,000 bill. $15,000. I'm gonna have to pay that in addition to all this other stuff. Maybe I need to find another hospital to get my procedure done in. Thought? How many times would that have to occur before the hospital talks to that individual and says, maybe you need to get in network? We also want to be sure that if a patient goes ahead and has the procedure done, that the bill is sent out in a timely manner. I was talking to my pastor the other day, and he said some of his folks at church, people I sit with every most Sunday mornings at 8:30, some of those don't get their bills to 12 to 14 months later with a little note attached, either pay me or we're going to turn you over to a collection agency. Well, this bill, there's a slight change to that. Said the bill has to be sent out within 90 days from the hospital once the patient is released. And then we're looking at the patient having adequate time to get with the insurance company to negotiate a payment. You know, most of the time when these patients get these bills, they don't have the access that those sitting around this table's got to talk to the insurance commissioner personally, or to call the head of a hospital and say, no, this is State Representative Richard Smith, and all of a sudden he perks up and listens. Most of your average consumers don't have that option. So our job here is to protect the consumer. And we tend to forget that. And that's the purpose of House Bill 71. Even that part that some of the organizations don't like, but that's all right too. But they have to have adequate time. And then if we have to go to arbitration, and it won't be, the arbitrator will not be an insurance company. You know, that was the furthest thing from my mind. The arbitrator would be somebody like the insurance commissioner's office. So these are the kind of issues I think it's important that we have transparency, that the patient, when they enter the hospital, knows what the cost is going to be, know who is and who is not in network, and if they have the option, here in Atlanta you got some options. You know, you go down to Southwest, you go down to Thomasville, you know, you don't have a whole lot of options. You may not can tell the hospital, I want to go somewhere else. There's nowhere else to go. There's not two hospitals there, you know. We've got one hospital or two hospitals in Columbus, general purpose hospital type thing, you know, St. Francis and the medical center. And the medical center's been taken over by Piedmont Healthcare probably next year, then make Piedmont the largest healthcare system in the state. But you know, a lot of this stuff has to do with transparency. That's what we're here to talk about today, to ensure that the patient has a clear understanding that all this information is on the web also. If a patient wants to go see what a hospital normally charges for a procedure, it should be there. You know, why is everything so secretive? Why? When I go, I had a little procedure done this past fall, and I was sitting there talking to the lady about with my insurance card and all, and I said, how difficult would it be for you to tell me because I had a little inside information she didn't know about. Concerned I've been talking about this for 3 years. How difficult would it be for you to provide me the information about who is and who is not in network as far as my procedure is concerned? It'd be okay. It's all on computer. Now that's with the understanding that there's no complications. You know, example might not be a good one, but it's an example. Your child go in for a tonsillectomy, and all of a sudden, I don't know, you may have known it before, but it turns out to be a bleeding situation. You have to call in a specialist. Well, that's not what I'm talking about. I'm talking about that kid that goes in for a tonsillectomy and everything works like normal. They'll at least know what that cost is. Be laid out in front of them so they can make their decision. That's where I'm coming from. I want to be sure that we know, or the consumer has as much information as they possibly can in order to make an intelligent decision. And I don't think that's all that difficult. So, does anybody on the committee have anything they'd like to say? Please don't just sit here with me. Talk. Okay. Who we got on wants to talk? Derek Norton from MAG. Where are you? Okay. You want to come up to the front table? And whenever somebody comes to speak, please identify who you are and what organization you represent, both parties, so that when we since it's being televised and all this, everybody will know who's talking. So, Derek, go ahead.
Well, thank you, Mr. Chairman. I'm Derek Norton. I represent the Medical Association of Georgia. This is Bethany Scherer, who also represents the Medical Association of Georgia. I want to thank the committee and you, Mr. Chairman, for having me here this morning. Thanks to Dr. Newton, Representative Silcox, and Hatchett for also being here. My comments are going to be relatively brief this morning. I had a long conversation, as you mentioned, with you yesterday, and I want to thank you again for being so generous with your time, Mr. Chairman. We've agreed to set up a meeting upcoming in the next couple of weeks with all of the specialty groups and you to talk about specific concerns about the transparency language in House Bill 71. I'm here this morning to report that the Medical Association of Georgia and the Coalition of Specialties, some of which you'll hear from this morning, that have been involved in this issue for the past 18 to 24 months, is working hard to find solutions, in particular with the transparency piece. We've sent language edits on this transparency sections back and forth, as you mentioned, over the last week or so in preparation for this hearing within the specialty groups in the House of Medicine over the last few days. There's several specialty-specific concerns that still remain, yet to be addressed and ironed out, and you may hear some of those this morning as well. I anticipate that the remainder of the concerns and questions, particularly for those groups and specialties that were not able to be here today, will be aired out and ironed out when we meet with you in the next couple of weeks. All of that said, MAG and our coalition at this time do not have consensus on our edits to the transparency language to submit to the committee this morning. It continues to be a work in progress, but we're hopeful to find a solution here relatively shortly.
Can I break in for a second?
Yes, sir.
All we're talking about is transparency.
Correct.
What part of the transparency element is the Medical Association having concerns with?
It's specialty-specific concerns, for example, from pathology being required. This is just one example of many that I hope to iron out. When they're talking about informing about the estimated cost of service, how widely that can vary. For instance, when they're taking the type and number of tissue specimens that might be tested, they don't know how many or how much that would be in that particular circumstance. That's just one of many examples, but those are the types of specialty-specific concerns that we hope to address in some language tweaks that will accommodate that, but still accomplish the goal of being transparent to the patient.
Okay, well, let's look at an example of the tonsillectomy. You know, they're probably in a normal procedure, one that has no complications. Should they or should not they know basically how many tests they're going to have to run? Because the thing I'm concerned with, and I guess we just probably need to go ahead and get it out on the table now, is you got groups of providers who have exclusive privileges at a hospital. You know, they're the only game in town. You can't select them. You can't do anything. When was the last? I'm gonna pick on the anesthesiologist since I met my new friend sitting over there. When was the last time you made an appointment to go see an anesthesiologist? Well, you don't. You wake up, you say hi to him, and the most important thing, he puts you to sleep, but the most important thing, he wakes you up. So, you know, you can't make an appointment with him, or you don't. That pathologist you just mentioned, he's the only game in town in the hospital. You can't pick and choose what pathologist you're going to have. Your radiologist, and I'll pick on Becky back there, your radiologist, you can't select those because their office and they're the only game in town in the hospital. Now, I'm only talking about these conditions that you schedule, not emergency room. We'll get to you later. But so, you know, you don't have an opportunity to pick and choose. All you've got is what the hospital sends in there. So why should they not have what the cost is going to be for a procedure that is planned? It's a procedure that there are no complications to. Why shouldn't they have what it costs?
I don't disagree that they should. I would maintain that there are some variables amongst the specialties specifically that can vary widely. I know Jet will speak to that when he's up testifying, but that's just an example of the types of nuances and specialty-specific concerns that we have. We do want to find a solution. We are working toward a solution, but those are the things that we've got to work out to get there.
Okay, go ahead.
I do want to mention before I close that the last time this committee met in July, we were instructed that the data from the Department of Insurance data call would be available on August 1st or on or around August 1st. We understand that a few unforeseen circumstances led to delays, but I want this committee to know that the Medical Association has just received that data as of Friday of last week. Once we've had a chance to adequately review and analyze that data of the insurer charges or insurer payments, we look forward to discussions about how that information might play a part in a final solution to solving this issue.
Can I interrupt again?
Yes, sir.
Sorry, committee. Y'all can speak up anytime. And you and I talked about this yesterday.
Yes, sir.
At length.
We did.
With the data call, they also incorporated for the various CPT codes what Medicaid would be, what Medicare would be, all the way from the out of network and all the way to Fair Health. And because I know Senator Unterman's bill, and I want to give credit where credit due. A lot of this transparency part I got from her. It's part of her bill, and we've kind of made some little minor tweaks to it, but a lot of that came from Senator Unterman's Senate Bill 8. I want to give credit where credit's due. With Fair Health, if we go that route, and I have some serious reservations about going that route, and based on a CPT code, whether it's whatever it is, and I think it was 150 in that data call or however many there were. That's about right. Yes, sir. For a particular CPT code, and the state is broken up into two regions based on Medicare. You got Atlanta, and then you got the rest of the state. Okay, if you got a CPT code here, let's say outside of Atlanta, and Fair Health is, say for easy math, $1,000. That's what the payment they recommend based on what their procedure is for coming up with that $1,000. It's $1,000. And I'm probably going to ask the anesthesiologist this too when he comes up. Why in the world would a anesthesiologist who is world-renowned, or neurosurgeon, or somebody who does heart replacement, why in the world would one of these world-renowned physicians accept the same payment as the guy who just got out of med school?
Well, I think, going back to our conversation yesterday.
Because if I was him, I wouldn't.
Yes, sir. And I understand your concern. I think going back to our conversation when we were talking about the Fair Health database or 80th percentile of Fair Health or whatever percentile that we came up with.
Okay, let me break into that too. I hate to keep interrupting, but this is not the Richard Smith show, folks. But yesterday when we were talking, and this happened in the Senate last session, it was Senator Unterman bill proposed 60% of Fair Health.
Correct.
Okay, it went to committee. All of a sudden it got jumped to 80% of Fair Health. Okay. There is nothing this legislature can do to fix that at that amount. We cannot tie the hands of the next General Assembly because it may, if we pass it this next year, it'll be set for until January of 19. But come January 19, you'll have a group come in and say, no, we don't think it should be 80%, we think it should be 90%. Well, all of a sudden it gets passed to 90%, and then next year around, or 2 years from that, it goes, well, we don't think it should be 90, we think it needs to be 100. Now, you can't tie the hands of the future legislator. So when you start doing something like that, you're leaving the box open for everything to get out. Now, you could pass something that says, okay, you could do the usual and customary rate based on the data call and require the insurance commissioner's office to do that data call every year. But still, that could change. So, what I'm trying to do is, get the patient out.
Right.
And we kind of forget that.
Well, so I think taking a step back, when I mentioned fair health as kind of the insurers have said that's too high, and some legislators, including yourself, that's too high. I think when my comment about reviewing and analyzing the data from that data call, my hope was that would kind of be the other guardrail, and then we would be able to come to a compromise. And I'm not saying, in any good compromise, not everybody's happy, right? But maybe if we can come up with that out-of-network payment rate, then that does take the patient out of the middle. And I know you mentioned that there are physicians that are more experienced or more sought after than somebody that's maybe just out of medical school. And I know that there are some winners and losers in that scenario where you've got a set payment for out-of-network. But my take is that may incentivize some of those physicians to get in those networks. And at the end of the day, we're really focusing on getting the patient out of the middle, not the discrepancies between different physicians in that.
Well, would it be fair to say for out-of-network payment to use the usual and customary rate based on the data call versus?
I don't have an answer to that because I haven't had a chance to analyze or review that data yet.
Uh-huh.
So I don't know. I don't know. I mean, that was the whole reason that we did that, was because it was proprietary and they wouldn't show us. So how could we possibly agree in legislation to something that we hadn't seen yet? So now we've seen it for a few days, still looking at it. Need another, I would say, another week to 10 days to at least digest and analyze that, to figure out, okay, well, where is that common ground, if there is any, on, with the insurers and fair health or whatever that ends up being. But that's what when I speak to finding a final solution to get the patient out of the middle, I think the one important component is reviewing that data and see what it actually looks like.
Mm-hmm. I would be surprised if the anesthesiologist sitting back there would be real happy knowing that he would be receiving the same as somebody first patient. And I think that first patient might be a little nervous too. But okay, go ahead. I'm sorry.
That's the end of my comments. I'm happy to answer any other questions that anybody else has. But I want to reiterate, MAG is committed to finding a solution, and I know the subject of this hearing is transparency language in House Bill 71. That's what we've been working tirelessly on for the last week since we've been preparing for this. But to your point in our conversation yesterday, we have been working on this for 2 years. I mean, lived and breathed it all last session, and so we're committed to finding a solution, and we appreciate your time on this issue.
Okay, we got a question, Ms. Taylor.
Thank you, Mr. Chairman. It's kind of a comment that goes along with it. I too appreciate it, and the data will make a big difference. But directing the percentage of the data call and reevaluating it every year, been down that path, and all that happens is you raise the charges and then mark them up 20%, and then in 2 years you've got a 20% raise. So that's a concern to me, and we know how that has gone in negotiations. So it has merit. But again, you're going to have to look at it. I don't like having to be a gatekeeper and going back every year and changing it and analyzing it. Again, it's merit, but we'll have to address that end of it too. Thank you.
Thank you, ma'am. And one thing I don't like, and I don't think we legally can set compensation. I think that's a legal issue, and I don't think we can do it. Okay. Do you got anything you want to say?
No, sir. I'm just here.
Just making him look good? Okay. All right. Very good. Thank you, sir.
Thank you.
Well, Jet, since I've been picking on you, I'll let you go next.
Mr. Chairman, members of the committee, I present to you Dr. Matthew Klopman, anesthesiologist at Emory, and Dr. Klopman is also the president of the Georgia Society of Anesthesiologists and has been actively involved in that organization for many years.
But did you put me to sleep in 2013?
No, sir.
Okay.
But I would have woken you up.
Oh, you were, okay, that's good. Because somebody there did when I had an ablation procedure, so. Go ahead, Jet.
All right. Mr. Chairman, as Mr. Norton from MAG stated, we are also committed to creating a more dynamic and effective consumer education platform that will empower the consumer to know more going into elective procedures. And my commitment to that is true and good, and I intend to push my clients toward that, and they are interested in that. And in fact, over the last 3 months, we have been talking about best practices for the individual anesthesia groups to engage to better educate the consumers, that is the patients, as they onboard for elective procedures. As you know, anesthesia is delivered in surgical centers, in offices, and of course in hospitals. The distinction for anesthesiologists is they don't pick their patients, and that is certainly true for hospital-bound radiologists and pathologists. So anesthesia has its own distinctions. Excuse me, the billing and the timekeeping involved in creating an anesthesia bill is different than for the other specialties and providers, and Dr. Klopman will address those. I think it's a surprise for almost every patient to get a bill from anesthesiology. I think that's a surprise because, as has been for me, the few times that I've gone in for a procedure, a routine procedure, I did not even think about the anesthesia bill. So it's not surprising to me, Mr. Chairman, that patients are surprised about an anesthesia bill. And so that's one dynamic of the conversation there, just the original surprise bill, so to speak, from a provider that is not considered. Again, I think the patients feel, they go into a hospital setting, for instance, and they anticipate there's one charge for everything, and certainly it's not that way. Dr. Klopman, I've asked him and put him on the spot this morning, and I appreciate him taking time out of his practice to address some of these questions. So I've asked him to talk briefly about what the GSA is doing, the conversations we've had, and then also to talk to you a little bit and educate you a little on the distinctions for anesthesia billing. And it will be helpful for you on this level to know it, and of course as a consumer yourselves. And Mr. Lumsden, I hope you don't have to be a consumer here soon on that need. Okay. Dr. Klopman.
Good morning. I'd like you all to know that the GSA is having very active discussions about providing the consumer transparency that I believe this committee and many Georgians are seeking. Along those lines, we have discussed a number of options, but most importantly, we believe that it should be very simple for a patient to determine, like you, who is in network. This should be something, this is the lowest bar we should all be able to clear. It should be no surprise when a patient goes in for a procedure whether any of the providers that touch that patient during their care are in or out of network. There are a number of ways this can be accomplished. Some of the language suggested that this be done by a physician, by a proceduralist, by the hospital where a patient goes. Those are some wonderful options. There are other options, right? When I think of an insurance policy, even the one that I carry in my own pocket, that I look at as a contract between me and my insurance company. And I think that I would expect that I'd be able to very easily query my own insurance company's web portal or even app on my smartphone to determine if I'm going to go to X hospital and have a procedure with Y proceduralist, surgeon, endoscopist, anyone, what other providers do you contract with at that hospital? Similarly, I should be receiving from my proceduralist or the hospital a list of groups and physicians who provide these related services that you've already mentioned, so that I can very simply look and say, I have my list from the hospital or my physician, my proceduralist, and look, they're all covered, they're all a network, or they're not. So I think that's the first step, and I agree with you. We are actively working to tweak this process with you to ensure that this seemingly easy thing to accomplish is accomplished. In terms of giving the consumer, the patient, an idea about charges, we also agree this is very important. And this is something that we should be able to provide. With anesthesiology, we have set charges. Groups do, individual practitioners do. One of our concerns lies in this concept that when we provide you with an estimate, we want that to be a good estimate. And you made mention of a tonsillectomy. I think that's a great sort of test case to discuss. Anesthesiology charges, unlike surgeons, radiologists, pathologists, have both a procedure component and a time component. Whereas a radiologist, they're billing an interpretation. There's a type of study, it comes with a set interpretation. A pathologist, now we may not know how many tissue stains need to be done. Anesthesiology is the procedure. So if you're having a tonsillectomy, I can tell you very simply, here's a charge for a tonsillectomy. But if things go differently than I intended, either because the complexity changed, if bleeding were to occur and all of a sudden we're having to do more activities to take care of the patient clinically, I'm having to put in new lines that weren't there before, I'm having to transfuse a patient to take care of them during this acute moment. Not only are the types of care that I'm providing escalating to meet the patient's need, but the amount of time that patient's going to spend with me is increasing. And because, like I mentioned, an anesthesiology bill is the type of procedure, the type of patient, but also the time, I would like to provide an estimate, but if we go hours longer than I intended, the bill's going to be larger. And what does a patient do when they've been given a projection of X and a bill of Y? And I think that our transparency needs to be able to accommodate that variability, not variability that's given out of malice or malintent, but that comes out of the increased work effort and time needed to take care of that patient's acute needs in the moment. So we're committed to getting there, but that's kind of one of the nuances of anesthesiology billing. We don't pick our patient. We often don't pick our surgeon. Right? And there are people who can run a race in 5 minutes. There are people who can run that same race in an hour. We take care of all of the patients and all of the racers, right? And so that's sort of what we're looking at and trying to come up with a way to provide that transparency in a way that accounts for the unknown variability in taking care of each patient as they come.
23.
Thank you, Thank you, Mr. Chairman. Chet, good to see you again. Good to meet you, Doctor. Fortunately, I've never needed anesthesiology, but
That's excellent.
yeah, it is. Jet, I worked a fair amount with Georgia Hospital Association and MAG on this issue. But in regard to the anesthesiologist, I completely agree that anesthesiology, as I know the practice, is completely different. You don't pick your patients. I think that's a very good point, and I don't dispute that at all. I'm just wondering what is the Georgia Association of Anesthesiologists, what is your proposal? I thank you, Doctor. I appreciate your comments in regard to transparency and working to have some assurance as to costs and a good faith. I think you're talking about a good faith estimate. It's maybe a real estate term, but we could probably transcend that to healthcare.
Absolutely.
Sure. So I guess my question, Jet, is for you. In regard to the chairman's concerns, what is the Georgia Association of Anesthesiologists willing to agree to as far as legislation in regard to transparency and so forth? I understand there's lots of interest in this issue from various groups all over Georgia. Many are represented here today. But what is the anesthesiologist solution legislatively?
Well, we're not prepared to give you that solution today, but we are certainly working on it. You have to uncover a lot of ground with hundreds of anesthesia practices around the state before we can come to you with language or a statement. I feel like we're in the discussion stage, Mr. Chairman, as you have, and I have done on at least 3 occasions. So, Mr. Carson, not to disrespect you, but we're not there yet. We believe that this entire discussion needs to start from a platform or a basis that the contract in this proceeding is between a patient, the insured, and an insurance company, the insurer, and that much, as Dr. Klopman said, much of the responsibility for awareness of who is an in-network provider is with the insurance company. We do not
Jet,
believe.
can I-
Yes, sir.
You say it's with the insurance company, and I agree, all insurance companies need to keep their data current.
Yes.
But when the patient goes in, he or she does not know what anesthesiologist is going to be there that day to put them to sleep. So how are they going to, when you go in, sometimes you're not in, because they give you a little happy juice right before you, they give you, put you under, and that's when you meet him or him or her, and most time you don't even remember seeing them.
Right. Again, Mr. Carson, part of our discussion has to try to understand all of the nuances that occur for the specialists who are backing up the surgeons, so to speak, if I can use that term. That's probably not the right term, but supporting that procedure. Anesthesiologists are taking care of the patients long before they see you, and then long after. They're your advocate during the procedure, and your only advocate, by the way. So high five to the anesthesiologist.
The rest of
their
them are
job.
beating up on you,
That's right.
cutting you and all that kind of stuff.
That's right, and that's an important consideration. The one approach, of course, is that the anesthesiologists are in a practice group, and that practice group either has a relationship with the insurance company, that is a contract to provide services to their insureds, or not. And so we think that that's going to be our starting point, is in trying to work with the patients to equip them with a pathway where the patient can go and get the information from the insurance company. Now, just prior to this meeting, Dr. Klopman and I were talking about some situations where a new anesthesiologist that has come into that practice may not yet be credentialed into that insurance plan. So that creates some problems and some challenges.
Well, since you brought it up, can I, since you're talking about credentialing or being in network or not, and it's like I mentioned, the most number of complaints I get relates to
Right.
anesthesiologists or surprise bills that they get. Why aren't anesthesiologists in network? Why don't you have exclusive privileges at the hospital? Your organization, your provider group is probably the only game in town in that hospital, especially if you go in a rural community or outside of Atlanta area. There's only probably one anesthesiology group in the whole town, and they may service both hospitals. In Columbus's case, why aren't they in network? Because one of the issues with being in network says you cannot send a surprise bill after that. You accept what the insurance company provides, or y'all agree to. It's not the hospital agreeing to it. It's what you as a doctor or a anesthesiology group agrees to. So the question is, why aren't anesthesiologists in network? And as a supplement to that, House Bill 71, you know, I know a lot of provider groups talk about narrow networks. You know, well, House Bill 71 said that if you have privileges at a hospital, the insurance company is required to put you in network. You have to agree to their, you know, y'all have your own negotiations. Hospitals don't do it. The doctor group does their own negotiations. But the insurance company is required to put you in network. And we added a little stipulation to that because we keep hearing that, you know, the insurance company's gonna lowball us. You know, they're gonna give us the bare minimum. Well, we put an extra little sentence in here, and we're gonna go over this in a little bit, but since you're talking about it, it says the insurers shall conduct all negotiations in good faith with obligations shall be enforceable by the commissioner. Then we added this extra little sentence. It says, a violation of such obligation shall be deemed an unfair trade practice. So, you know, if the insurance company is going to negotiate, they have to negotiate in good faith, or it's deemed an unfair trade practice. Would that encourage anesthesiologists, pathologists, radiologists to be in network so that balance bills will not be sent out?
To your first question about physicians choosing not to be a network, I think this gets to the heart of one's ability to negotiate. I sit in a fortunate spot, and that is that I am part of a gigantic physician group practice that is in most networks. So I speak on behalf of colleagues across the state and not my own personal situation. But I think what defines one's ability to negotiate a contract, because this really gets to the heart of that question, and I'm not going to answer the question, but that is really what we're asking, is can one negotiate a contract that is fair, right, in their own mind with their counterpart that they're negotiating with, and how much external influence do we place upon that negotiation? I think that all of us would like the ability to negotiate in good faith, but I think very much that how we define that good faith negotiation, because in the end, as I follow out the concept of the insurance commissioner being the arbiter of good faith negotiation versus unfair trade practice, we again, and how does one define that? We again end up in a similar position to what Derek described earlier and you and he dialogued about, which is what would define, what would be the metric by which we would look at a proposal from an insurance company? And
but you know, 95% of the other doctors in the state are in network. You know, I got a good friend who's an OBGYN, and I got a good friend who's a plastic surgeon. They're all in, and he needs to work on me, but they're all in network. Why can those outside of the exclusive privileges at the hospital, why can they negotiate a fair contract, whereas those who have a monopoly in the hospital can't? That may be an unfair question to you,
I want
but
to answer that because, again, we're getting back to the fundamental dynamic of being a hospital-based or a hospital-locked physician. The insurers know that Dr. Klopman and his peers are going to see every patient that comes in. They're going to give the same level of care. Dr. Klopman doesn't know the insurance status of any patient before he begins that care. And so we believe that the insurers are not incented to necessarily offer what might be considered a
even if
market
it's
rate.
deemed an unfair trade practice if they don't negotiate in good faith?
We don't know that because that's not been the law and not been enforced as a result of not being a law. I do want to say to every member of the committee that in talking with representatives from anesthesia practices all over the state, and certainly in the metro area, Representative Taylor, deferring to the differences and distinctions of Thomasville, that the anesthesia groups tell us that they accept most every contract that's out there. And now the anesthesia groups are incented to accept the contracts because the hospital is going to just naturally puts pressure on the anesthesia group that we're giving you this exclusive contract, and so you in turn should do the best you can to provide in-network services for those and accept those contracts. So there is an incentive to the anesthesia practice. They want to keep that exclusive contract because there's plenty of anesthesia practices that could come in and take that contract away, and we've seen that certainly in this state and around the country. So again, we believe that while your phone rings a lot and you hear and other members of this committee and legislators hear or suffer a surprise bill, hear about or suffer a surprise bill, that it's a relatively small number out of all the many hundreds of thousands of procedures that are done in the state.
Mr. Chairman?
Yes, sir.
I'm already on it. I just, can I ask one question to you about, if we're talking about balanced billing in regard to frequency and the amount of dollars and so forth, is the anesthesiologist billing in regard to balanced billing within the state, is it a 5-10% of the overall issue, or is it 50% of the issue based on what your understanding is?
I don't know what the exact percentage is versus the four groups that the Journal of American Medical Association
Sure.
did their thing on. But based on my calls,
Okay.
that's the
Constituents and anecdotal evidence.
right.
Well, I was just going to say, it's late September. We have session coming up in 3 months. I would just plead, beg, what have you with the anesthesiologist because of the chairman's experiences and understanding. Let's have some sort of solution.
Oh, we're going to meet quite often.
I look forward to it. I just
Well, not necessarily us, but we're going to meet quite often, and we're going to get it resolved.
Yes, sir.
Thank you, Mr. Carson. We appreciate your passion for this. Mr. Chairman, I would like, since you brought it up, for Dr. Klopman, to ask Dr. Klopman to address salary determination of anesthesiologists, because I do think there's a misconception about the relationship between the fee that is charged for an anesthesia procedure and an anesthesiologist's salary. So, Dr. Klopman, may I surprise you with that?
He's even
no.
worse. He's even worse than we are.
I'm telling you. I think it is fair to say that most of us practice in practice groups, and that it's important to know that the relationship between payment for any given service and the salary of the providers working in a group is not related well at all. In fact, many groups are somewhat egalitarian, maybe is the best way to put it, in that some do work that generates more revenue than others, but at the end of the day, like many other groups out there, it is all shared. So the I don't know if that's what you're getting us to, Jeff.
Right. So an anesthesiologist who has been in practice 30 years is probably going to have a higher salary by virtue of some ownership in the practice group. That may be one factor, or the expertise that anesthesiologist has developed through the years, through continuing education, through experience, through additional training, and it is not based. That higher salary is not based on whether or not there's an in-network payment or an out-of-network payment,
Sure.
or Medicare or Medicaid, because you yourself treat patients with all payment, in all payment streams and no payment streams,
Correct.
correct? Okay. Just,
Okay.
we think that's an important clarification.
Yeah. Ms. Taylor?
Thank you, Mr. Chairman. I kind of wanted to get back to where we were going, which was looking at how you determine fees. And I've had the good fortune to, a number of occasions, had anesthesia. And yes, I woke up every time. But something that was very different from sort of what I'm hearing is I met my anesthesiologist before I ever went under, and he sat there and he had my record, and he knew and was treating me as a full patient, though he was just administering the anesthesia. So I do think that's an important part, and in evaluating how an anesthesia fee is determined, it is based on a time and charge, but I think that the procedure code itself could have a factor. And then the time is usually determined in 10-minute increments. You watch the clock, and I get those reports. I'm a payer, so I do know you can look at it and determine that. And it does change. One tonsillectomy may take 30 minutes. Another one may be an hour and a half. If there's an hour and a half, we got a problem. So it would increase on that basis. But you still could have the procedure itself have a value, and the time, each time unit has a value. So there is still a way to make it transparent to the patient. You don't have to say, my fee is going to be exactly $932.50. It can be based on that, and there would be variance. But it is important. I think we want to make sure that the patient relationship with the provider is accounted for and addressed. At the same time, there's got to be some ability for the patient to know in general what to expect. And I think that's where we want to go to. I'm not looking to tell you you're going to make this amount of money every time you treat a patient for tonsillectomy or appendectomy or whatever it is. As we go forward, I think these type of issues need to be addressed, and there will be variables. Frankly, I get some anesthesia inquiries. I don't see this traditionally as the biggest issue. Frankly, I have more with pathology. And that's a whole different world of medicine. But anesthesia it does come up, and the patient doesn't have a choice. This is what I hear from my constituents. So they just want some warning, whether it comes as they're admitted or whether it's coming from their primary surgeon or physician to what to expect. Again, I've always known there's going to be an anesthesia bill and a pathology bill, but every consumer is not in this industry, so they don't see it. We've got to find some way, and I think these open discussions are very helpful. Also, part of it is the consumerism that somebody gets this bill for $1,000 for a 15-minute surgery, and they're wondering why they think the anesthesiologist is making $1,000, and they have no recollection or understanding that there is overhead in operating a practice and things like that. I'm not saying disclose how you operate your business, but we do need to make sure that the consumers are involved in how we set the price and how you determine it. The other important factor is, and I can attest, I've had providers come to me with issues with carriers. And I don't tolerate when carriers are not above board and come into the table like they're supposed to. And I've more than once called them on the carpet for not meeting those contracts. It's got to be fair. And I think we all understand that. That's the most important thing that every one of us up here want to make sure, that it is fair to all the players. We're protecting the consumers, but quite frankly, doctors are consumers too, and they're constituents. And I need to make sure that they are treated fairly and the carriers understand that. Thank you.
Thank you. Representative Shannon.
Yes, I just wanted to add a couple of comments on some of the comments we heard earlier about, every time we think about new legislation, we think about, is it a big enough problem to have something done, or is it just a small subset of folks that are being affected? I may be the only person on the committee who actually represents a metro district. Is that fair to say? Anybody else represent? Oh, you do? Okay. And so I just want to echo the concerns that I absolutely am really concerned about how this is working in rural areas where Chairman Smith said you don't have a choice. But I want to echo that in the metro area, I also get complaints from constituents because even though we may have more choices of providers to go to, you still have no control over who your anesthesiologist is going to be. And so, like like Representative Taylor said, in the areas of pathology, that's where I see more complaints, because you can, a lot of what we talked about today has been higher level procedures that require an anesthesiologist. But even in the areas of gynecology and other planned appointments and things that happen, patients don't have control over what lab that provider sends the specimens to. So I just want to echo that this is not only a rural area problem, although I'm sure it's much more pronounced. This is a big enough problem that it may not be affecting the majority of Georgians, but it's affecting enough that all of us have stories from constituents that this is an issue. So,
Okay. Representative Lumsden. Well, Chairman Lumsden, excuse me.
Thank you, Mr. Chairman. Thank you for being here, and thank you for your comments. Probably already touched on this, but I just wanted to clarify. Obviously, cost and compensation are important considerations in this discussion, and looking at the payment schedules are important. But from the consumer's perspective, getting those good faith estimates, as Representative Carson had mentioned, is very important. I assume in other areas or in other arenas that I've dealt with, often you get a good faith estimate, but those good faith estimates are hedged, if you will, based on the fact that there may be variables that are not readily known at this time. And I'm hearing that those things are there. Is there not something that you can, and I assume you know what an average procedure of the type that the chairman has mentioned would cost, assuming that there are no other problems that go into that? Is this not something that is pretty easily discernible and could be used as a basis?
I would say yes, quite frankly. We all have usual and customary charges for these types of things. Again, I think it's as long as we accept the fact that it is truly good faith.
Well, that's my point. I understand all of the variables that you're talking about, and it can get a little bit, but this is, it's different, but there are other areas out there where the same type of thing occurs. You get an estimate based on what you think the situation is going to be, and then when things happen, and you can legally handle that through the language in the contract or the agreement. So just my comments. Thank you.
Thank you, sir. I hope when we started off, I was talking about planned procedures that nothing goes wrong. When you got a regular tonsillectomy, normal tonsillectomy, you may have 20 of them, and all of a sudden you have one that's different. So those 20, you should be able to get a fair estimate of what the cost is. But that 21st one, where something goes wrong, and instead of taking 30 minutes, it takes an hour and a half, there's differences. Are y'all built on 15-minute or 10-minute increment?
It depends on the contract.
Okay.
Honestly.
I'd heard 15. I didn't know 10.
10 is what I use on usual and customary.
Oh, okay.
Manually.
Okay. Anything else?
No, sir.
Well, we appreciate what y'all being here and letting me abuse you a little bit. But we're good friends, and like I said in the beginning, we need to have open dialogue on this, on how we get this issue resolved, and we will meet. I think Derek is probably going to set this up where all the different specialty groups come in with particular interest, so we can take a look at that. So I appreciate what y'all do.
Yes, sir. And Mr. Chairman, if I might respond to Representative Shannon, we take this issue very seriously, and whether it's one complaint or 100,000 across the state, it's an issue that we're committed to embrace and try to be part of a solution, a realistic solution on this. So, and Mr. Chairman, thank you for allowing us to be here for our 10-minute brief testimony
Okay.
this morning.
I want to get your money's worth. Thank you, Doctor.
Sometimes things go a little longer than we think.
I understand. Yeah, just like that anesthesia. It may take 30 minutes instead of 10. Okay. Becky Ross. Georgia Society of Radiology. The floor is yours.
Good morning, Mr. Chairman.
Morning.
Members of the committee and guests of the committee. Thank you for being here today, and thank you for the opportunity to testify on behalf of radiologists in Georgia and also the radiology business managers. The radiologists and business managers work hand in hand on this issue, and we have been discussing it now for over a year, and in particular, we have done intensive work sessions at our conference and board meeting to address how to best resolve this problem that is prevalent around the state. I'd like to speak on 3 areas: the transparency piece, and then, Mr. Chairman, in our very first meeting that you and I had with a couple of radiologists, we share your passion about getting the patient out of the middle, and we agree that that should be a goal and is a laudable goal. And then finally, I'd like to share with the members of the committee some of the nuances regarding reimbursement in radiology and how that is different than other specialties and other provider groups. So beginning with the transparency, we thanked you the first time we met, and I thank you again. We believe that this transparency section will go a long way to address the confusion that is created for patients, and also we believe it will bring some clarity for providers in terms of the patients that they're dealing with, the business managers, and whether the patient is not in network or whether they are in network. Some of the issues that we will discuss with you when we meet as specialty groups are, for example, if a patient comes in and their insurance has not changed, or they state that it has not changed, but it has indeed changed. So our concern would be that the radiologist would be held to treating that patient as if they are in network, when in fact, if their status has changed, they may not be in network. Or if this verification is done prior to the patient coming in for a procedure, but then that status does change between the verification time and the time that they come in, then again, the patient could very well be out of network. And this indeed has happened where a patient, their status changed from the time that it was verified by the business office and they came in for their mammography or CT. And in that case, when the business manager submits the bill and it comes back, this patient is no longer our beneficiary, then they really have no other recourse but to send the bill to the patient, because that's the only other address that they have. The other piece that I want you to be aware of is for radiology practices, when the patients do find their way back to either the radiology group or the business manager group, most times they're able to resolve the issue directly with the insurance company and keep the patient out of the middle. So we think that that is something for that we'd like for you to keep in mind in terms of a pathway to truly get the patient out of the middle. Like anesthesiologists, radiologists don't choose their patients, and the patients don't choose their radiologists, and they oftentimes don't even see the patient. The radiologist is the one that they're in the dark room, and they're taking as much time as necessary, Chairman Taylor, to interpret a study on behalf of the patient. The last piece about transparency and the cost, we can certainly give a cost for each procedure, whether it's X-ray, CT, PET. However, the challenge with radiology is if a chest X-ray is ordered and the radiologist sees something that is of grave concern, then it may require an immediate procedure and a different procedure. So that can't always be predicted when the patient comes in for that diagnostic study. In your efforts to get the patient out of the middle, we have discussed with you, Mr. Chairman, that we would like a pathway through the Insurance Commissioner's Office as a go-to point for patients who receive a bill and they're either surprised or confused or both, And we are also appreciative of the Insurance Commissioner's Office and their Division of Consumer Services. And in fact, many of the radiologists use this division when they feel that they are not being treated fairly through requests for information or any sorts of delay in their receiving payment. And this division has been very responsive. So for those radiologists as consumers, they're appreciative of this division, and we think it could be a pathway for patients to have someone to advocate on their behalf to help them get to a resolve in the quickest way possible. Finally, the reimbursement for radiology, we just want the committee to be aware that for radiology, there are two codes. There is the professional component and the technical component. The technical component is billed on behalf of who owns the equipment, so whether it's the MRI, CT, or PET. The radiologist bills only for the professional component. And as you might imagine, the technical component is a much higher rate that is being paid versus the professional component. A chest x-ray, for example, a radiologist gets, the average payment is about $20. So you can appreciate that if, you know, if there is a balance bill on a chest x-ray, it's going to be a very small amount. Finally, the radiologists and the business managers look forward to working with you, and we are committed to work with you to find a resolve for this issue on behalf of consumers and patients in Georgia. I'd be glad to answer any questions, Mr. Chairman.
Anybody got any questions? You like you got it made there. I do have a question for you, and we've talked about this before. If I'm going in for a planned procedure, and we all know what the procedure is, and there are no complications, would there be any problem with radiology being able to give the price of a procedure? You know, like a chest x-ray, you say $20. Okay, so if I go to the hospital and I'm having something done, they have to do an x-ray of my chest, and the hospital knows that radiology is going to have to do an x-ray of my chest. Is there any problem putting that number down when you check in so that the patient knows exactly, within reason, what any particular provider is going to charge who is assigned to your procedure?
Yes, sir, that would be very feasible to do that. There are two things to think about, though. What if, when the patient is going in for surgery, the patient nor the surgeon may be aware that another diagnostic
Right.
procedure would be
But
necessary?
I'm talking about this is your tonsillectomy kind of thing, where you go in and have tonsils out and you go home.
Yes.
I'm not talking about if a bleeder develops or some other problem develops. I'm talking about just your everyday tonsillectomy, if there's such a thing. Whereas to ensure that, and I think if we do this, we're going to have some kind of notification on that document that says these are good faith estimates. If additional problems occur, like a child is a bleeder or something, then those kind of things would need to be put in there to justify why the difference in the bill. And people also need to know, us folks, they can't balance bill me. I'm on Medicare. Medicare is, you can't balance bill Medicare. You can balance bill that 20% you're not, that Medicare doesn't cover. You can't balance bill Medicaid. So you're looking at a small group of people here that we're looking at, just like when we passed a mandate bill. It's only that group, I think, that we're looking at, that your individual and your small business. That's the group where we're looking at here. But they have issues too. So it's, there's a lot of things there that, but I think that to me, the transparency part, if we can get by provider and then a total, and that the patient has the option then to say yes or no. You know, it becomes the patient's option. But up until this time, you know, for the times I've been in the hospital, my wife's been in the hospital, my kids have been in the hospital, whatever, I have never seen anything that showed me what the cost is going to be until after the procedure's done and we get that notification of what the bill is.
Yes, Mr. Chairman, that cost estimate is certainly feasible, just keeping in mind the unexpected in terms of if an additional diagnostic study needs to be ordered immediately, or if when that initial study is done and the radiologist sees that another immediate study needs to be done either to an adjacent body part or a different type of study, depending on what the radiologist sees. Some things show up on an MRI different than show up on a CT, for example. So those would be the unpredictable factors.
Okay. Chairman Taylor.
Thank you, Mr. Chairman. Thank you, Becky. It's good to hear from you, and I'm very encouraged by what you're saying. It does sound very much like there's consensus. We all want this information out there. We want the patient taken out. I would say that the secondary procedures, of course, would be billed separately, and you're right. How do you identify it? You go in expecting a chest x-ray. On that, it shows something. You end up, who knows what, with a GI series or an IVP, which are actually surgical procedures. These are injections, so there is a lot more time and skill that's involved in these procedures, and you would not be able to do that on face value upon admission. But again, there can be disclosures on there. The simple things will be there. The whole key to this, I think, is though we need to be able to get in network. We need to be able to have confidence, which I'm very glad, the confidence you've talked about. I too have confidence in the Department of Insurance. I do feel like their Division of Consumer Services is excellent, and they will get to the bottom, and I think they can be a fair arbitrator for us. But we need to have it so there's not a question. Yes, you're disclosed, you're going to have a chest x-ray. You may not even know you're going to end up with the secondary procedure, but there'll be confidence that you know to expect a radiology bill, and if they provide additional services, there can be a disclosure and letting folks know that if additional procedures are done, that will increase the cost. But letting them know to expect even that first bill. But again, I'm very encouraged because I think everybody here is recognizing this is not a simple issue, but there are ways to find solutions. So thank you.
Thank you, Chairman Taylor.
Chairman Lumsden.
Thank you, Becky. In addition to, say for instance, you have a procedure scheduled and you know what test or what readings are going to have to take place, and in the process we do have other things that might come up that they have to do additional. Are these not normal? It's not some specialty. I mean, reading for this could be different. So what I'm saying is, could there not also be a cost schedule for commonly performed readings of different types of things that might come up?
That's what's so difficult to predict, Chairman Lumsden, and that's a great question, but the beauty of radiology is that an image can show a clear picture of what is inside your body versus having to do an invasive procedure. So until the radiologist gets a clear view of what is exactly going on, then he or she can determine whether you need an invasive procedure or whether just another diagnostic study. So it is very difficult to predict. And Chairman Lumsden, thank you for your question. And also, I just wanted you to know that I consulted with one of the most iconic radiologists in the state last evening before coming here today, Dr. Dan Hanks. Your constituent.
I guess you know him, huh? Okay. Who's 18? Oh. Representative Cannon.
Thank you, Mr. Chair. I just have a question regarding the consumer portal that you referenced. reason why I'm on my phone up here is I'm trying to log in to the consumer portal. And you said that you were pretty, interested and felt good about what we could possibly do if we wanted to submit a complaint. What's the average time that it takes to receive that information back about the complaint? Because I'm curious if perhaps the person sends in the information, it still goes to collections and they're still in the same circumstance.
So they have been very responsive through that division, and oftentimes, if you call, you get a person on the phone, if not immediately, very quickly. And then the online response has been very, very quick as well. So, it may be something that would need to be some changes made to that division to be as responsive as the legislative intent of this particular proposition, but it has been done in other states and has served very well to meet the immediate needs of patients before the bills would go to collections.
Representative Taylor.
Hi, I just wanted to share with the representative, I use that frequently, and with all the agencies I deal with, they respond very, very quickly. They've solved even major issues within a couple of days. Again, it depends on the criteria, if you're trying to get somebody pre-certed, if you're trying to get a resolution to a bill, but I'm very impressed with how well they do. So, thank you.
Thank you. Well, that looks like all your questions. Thank you.
Thank you, Mr.
And
Chairman.
we'll be meeting shortly, too.
Look forward to it.
Okay.
Thank you very much.
Thank you. Dr. Pettigrew, and as he comes up, I want everybody to know that, I meet with these folks on a regular basis, and we all understand what the issue is, and we're all trying to get this issue. Thank you, sir. We're all trying to get this issue resolved, but what we want to do is when we drop the bill, and I hope we drop it early January or get it passed out of committee as soon as possible. And we may meet the first Wednesday in January this year, which will be a record. May not meet again until February, but we may meet the first Wednesday in January to get this bill passed. And there's a couple more we need to take a look at. But they've been very cooperative in trying to get these issues resolved, and you can tell by the testimony that they've given, they understand what the issue is. Okay, Dr. Chip Pettigrew, Georgia College of Emergency Physicians. Hey, you got a sidekick over here.
I do, a great one.
Go
Thank
ahead.
you, Mr. Chairman, and as previously instructed, I will again introduce my name and who I represent. I'm Dr. Chip Pettigrew. I'm a career emergency physician from Athens, Georgia, and I represent the college, the Georgia College of Emergency Physicians, and am a past president of that organization. I appreciate you inviting us today, giving us this opportunity, Mr. Chairman, esteemed committee members, and honored guests. Thank you for coming. As you can see from my first page of my prepared testimony, I'm prepared to talk about the Georgia Department of Insurance Contracted Rate Data Call Report. I'm prepared to talk about, as requested, how emergency physicians arrive at their fee schedules. I'm prepared to talk about transparency issues for out-of-network balance billing, and I'm prepared to talk about arbitration and anything else that you all might bring up.
Okay, can I
Mr.
make it
Chairman?
so let's forget the one on the data call because they found some discrepancies in it.
I was going to point those out. So
Okay.
thank you for saving
right.
my time. I will move to the next page, how emergency physicians arrive at their own fee schedules, which I believe was the question that the chairman had for the Medical Association of Georgia. I'm experienced as a medical group partner and administrator and a consultant in emergency medicine. Most independent emergency medicine groups make annual budgets, which include, among other items, the cost of recruiting, hiring, and retaining well-trained emergency physicians dedicated to the specialty of emergency medicine and to the community. The costs of overhead, such as malpractice insurance, health insurance, and other benefits, processing bills for services rendered, etc. The reimbursement rate, which is critically low for our specialty, and other items which may occur, such as in my own group, we annually contributed to the local empty stocking fund each Christmas time. In the past, we had used Ingenix as a reality check for our fee schedules, but once it was successfully challenged in court in New York State and subsequently retracted, we had to bounce our proposed fee schedules off a more trustworthy and independent source, and have since used Fair Health as a source. I believe that many independent groups follow a similar analytical approach to setting fee schedules. I'm prepared for questions on that section.
Go ahead.
Regarding transparency, I want to go off report for one moment and say that Georgia's emergency physicians are 100% behind transparency. Other than that being a very complicated issue to implement, the concept we are 100% behind. We couldn't be stronger advocates for our patients on that matter than anybody else in this room. Transparency issues for out-of-network status may possibly work for elective services, but they're not likely to be able to come to play when a person has an emergency and needs emergency evaluation and care. And I think we all understand that, and that's why the chairman limited this to elective procedures. Proposals for transparency for elective services have some merit if they're not too burdensome, and if penalties, if any, for providing coverage information that may no longer be up to date are not too severe. I can attest that as an emergency physician, one of my biggest time-consuming efforts is trying to identify which doctor is covering for insured patients who need to be urgently admitted to the hospital. Not emergently, because then, of course, there's no concern for insurance status. Doctors and insurers are constantly changing network status, and it's virtually impossible to determine with any certainty who the proper on-call doctor will be for any given insured patient who requires urgent admission or urgent follow-up.
Okay, now run that by us again.
Trying to figure out who's actually in network for a patient's particular plan is close to impossible in the emergency department. When a patient needs to be urgently, we've stabilized them, they're no longer an emergency, and we have time to help sort out their insurance and get them to the proper doctor who can cover them on an in-network status.
Because you don't have a choice on who you see as far as a patient. Whoever walks in your door is your patient.
Under federal obligation is
That's
see
right.
anybody and everybody, regardless of insurance status or ability to pay. And we revel in that honor.
Okay.
So the difficulty is for an urgent patient who needs admission or a patient who needs follow-up. We've stabilized an ankle fracture and they need to see an orthopedic surgeon within the next 3 days. It's trying to figure out who on earth is in network status to refer them to. It probably takes an hour and a half to 2 hours to get that sorted out, and then we hope we get it right.
Okay, so you got a patient there that's got a broken ankle and that you've stabilized it, and they got to see an orthopedic surgeon within 3 days. Do you have orthopedic surgeons who are on call at that hospital? Because a lot of hospitals have on-call orthopedic surgeons for.
Yes, sir, we do. We have multiple groups.
And
that's the issue.
Uh-huh.
We want to get them to the right orthopedists that are in network with, for that
Can
patient.
I run something by you? And
Yes,
we've
sir.
had this discussion before in part. If a doctor has privileges at the hospital, or providers have privileges at the hospital, why not be in the same networks the hospitals are?
There's some
Now,
merit-
that's with them doing their own negotiation. I'm not saying that they have to be, they're in the hospital's insurance plan, and the insurance does the negotiation. If you're trying to find somebody who is in network for that particular patient, whether they're in United, Cigna, Blue, whoever, doesn't matter. If the hospital is in network with those insurance companies, would it not be much easier if they were in network? Because you could find them then. Because
Yes,
if
sir.
they got insurance, they're probably in network.
I want to just describe a few complicating factors.
Okay.
I'm not opposed to a simple concept at all, but there are complicating factors. One is the hospital actually may not be in network.
Well, you know,
For
if
that
you go down
patient.
to Columbus and you're from Atlanta and you end up down there and you got Kaiser, you're not gonna be in network in Columbus.
Exactly.
You know, Kaiser's only up here, so
So-
that, you know, but then you charge a usual and customary rate that you would charge if they were in network, or should.
So that's one issue. Another issue is if you look at the emergency medicine CPT codes on the data call, and you look at, say, a significant level of service, a 99285, which is our next to highest, so represents somebody who's coming in an auto accident, has maybe neck and back injuries that we've stabilized, but and they're able to go home, for example. If you look at the insurance company's self-reported data, their minimum contract and their maximum contract are greater than 10-fold difference. To me, that shows the difficulty that physicians have in trying to have fair negotiations with insurance companies and why they are or are not in network. And if they're mandated to be in network with a hospital with a certain plan, then I know which range of contracted charges the insurers are going to be aiming at. And I think it puts physicians in an untenable position.
Okay. Now, you know, like we've talked before, and for everybody's benefit, he's been in my office several times. I don't know how many, but it's been a bunch. When we added the language that a violation of the good faith negotiation would be deemed an unfair trade practice, would that or would that not give you more comfort in believing that the negotiations then would be fair? Because like we've said before, if you get out of the hospital setting, 95% of all doctors out there are in network, and they don't feel like they've had a problem. Yeah, they might like to get more, but they've had fair negotiations with the insurance companies. If and especially when we add that unfair trade practice, if they're not negotiating fairly.
I like the concept. I'm not sure how it would work out in practice. I know of many state laws on out-of-network balance billing, and I don't know any that have an approach like that to see if there's a track record to show how much of this ends up in court, how much it delays the payments.
Yeah, but see,
I'm
we don't
just
we
not
don't
sure
want
about
we
how
don't
that
want
would
to
work.
do something like Pennsylvania. They passed a law across the board, no balance billing, period. Well, at least this way, it gives you an opportunity to do or have in-faith negotiation for that group, because all the other groups around outside of the hospital setting are in network, and when they come to the hospital, they're still in network. That's
I would like to consider that concept more.
Okay.
It's a brand new today to me proposal, and I would also like to run it by my colleagues. I would like to say, as an aside on your comment, most emergency physicians are in network with most plans.
Okay.
It's just the very few that won't negotiate fairly. When you see that insurance companies at a level 4 in outside of Metro Atlanta are paying a range of 10 times higher from the lowest charge, and then the
now I read some of those interesting numbers
other,
on that data call.
It's just all over the map, and it just shows me that right now we're in a situation where there's not fair negotiations. So I have to get over that hump to think of a future where fair negotiations might be a possibility.
Okay. Go ahead.
I would like to continue to work on that.
Oh, I got number Representative Taylor.
Thank you, Mr. Chairman. We've heard repeatedly discussions about fair negotiations, and they are difficult. And fair is going to be that word that everybody sort of hangs their hat on what is. But I do want to share with the committee that I had happened to be ER physician group that was having problems with the negotiations. everybody had sort of decided what they wanted and where their level was going to be. But getting everybody back at the table to sign off on it, somehow the ball kept getting dropped. And insurance commissioner's office was called and contacted. The carrier got the message from one phone call. The provider was happy, and it was resolved within 2 days. I think these are things that we're thinking are more difficult than they are.
Mm-hmm.
Sometimes everybody needs to be prodded to get back to the table, but really it can be solved. And I think everybody does need to be open to negotiations, and I think this is one of the reasons why I do trust the Commissioner's Office to be, we'll call it nonpartisan. They want to see the consumer satisfied. That's their division of consumer services there. So I do think there's a way to do it, and it is being fair. And when they're not going to be fair, they're going to be smacked down. And I think that's the important part. But it works both ways. I don't think, I will tell you, the doctors I work with would like to have made more money, but they felt like it was fair. Everybody, this is free market enterprise. The problem is in healthcare, it's not truly a free market. The end user is not the one that pays the majority of the bill, so it makes it even more difficult. So what we're talking in fair market, we're talking about the carriers who pay the biggest part of the bills and the providers that are providing the services. And we need that fair arbitrator, and I do have confidence that it can be done. Sometimes it is prompting everybody to get back on task, come finalize your negotiations. You may argue over one or two, but come to a conclusion. And I do believe it can be done. It can be done. We all have to be willing to do it without such a heavy stick as just no collecting anything. I think that's the last anybody wants. We need to have providers. I come from a rural community. We don't want to do anything to run doctors off, and this is a fair way to do it. Thank you.
Thank you, ma'am. And one thing that folks need to understand, especially the viewing audience, healthcare and insurance are probably two of the most regulated industries out there. We're probably close to nuclear energy, as far as being regulated. You wouldn't believe the number of rules and regs that providers and insurance carriers have to do. But go ahead, thank you.
Thank you, ma'am. As far as our arbitration, I was just this week made aware of the possibility of an arbitration proposal. In order to provide a full analysis of this, we need more specific information, such as the makeup of any panel, the guidelines for that panel when disputes need to be settled. And I think with that information fleshed out a little bit more, we would be happy to talk about.
Well, I think as far as arbitration, it would probably come through the insurance commissioner's office or some state administrative arbitrator board, not either the medical association or the insurance companies or something like that. This would be a state administrative arbitration board of some sort, so that both sides would get a fair hearing.
And my question would be, who would develop guidelines? For example, in California, in legislation, they say to use Gould criteria, and the Gould criteria state something that came up earlier today, that if you have a lot of experience, if your specialty does this single procedure and you do it great, then you ought to be able to charge higher than others. But if, so that's just one item of
Since you
interest.
brought that up, and you and I've had this part of this conversation before too, you got your gold standard on a provider, and they should be paid more. If I'm going to have a neurosurgeon or a heart replacement or something, I don't want a kid just out of college. I want somebody who's done it a few times, and who's been successful. If we go with the Fair Health Plan, then everybody get the same thing. Why would any doctor who is in that gold standard agree to that?
I have some thoughts on that because I've talked with many emergency physicians and specialists on this matter. The 80th percentile means that the top 20% of charges are discounted. And before they even determine what the percentiles are, they throw out all the outliers. So whoever the weird people are in New York that charged $100,000 for assistant surgery or whatever egregious thing that was, those sorts of things are thrown out by statistical experts.
Mhm.
Then they determine the percentiles. Most physicians I've talked to would be willing, who charge higher than the 80th percentile, and that's few, that's like 20%,
Mhm.
Would be willing to give that up to stabilize the market and to get patients off the hook.
But the problem is, that with the fair health, then, like I mentioned earlier, everybody in this room's premiums are going up.
Actually, we've discussed this also, and we would think that legislation should fix the charges at 2016 or 2017 rates and put in an economic cost of index inflation. And then that would freeze the charges at current level, and then just have inflation added to that.
Well, we'll have to talk about that, because one of the problems I see with that, anything we set can be unset.
I'm not a legislator.
Yeah, because, like I said, this group this year cannot tie the hands of the newly elected that comes in 19 or 18, 19. We can't tie their hands. So, well, we'll talk about that further, not take up the committee's time on that. Go ahead.
I also belong to another organization, a national organization called Physicians for Fair Coverage, and it's an organization of medical specialists to promote the interests of patients who are caught in the middle between disputes, and they have asked me to submit testimony for them today, which is included in my packet. And that's it from me.
Okay, now what do they do again?
They are a coalition of most of the specialties in medicine, the national specialty societies instead of the state specialty societies. And they have organized on behalf of patients to advocate for patients in finding solutions that get them out of the middle of the out-of-network balanced billing issue.
Okay. I also noticed in here that you've got a in-coil draft of out-of-network billing Transparency Model Act.
Yes, sir.
I don't know if you know this or not, but Representative Cannon, when are they meeting? When are they having a call? October 13th. In-coil is having a conference call on this for in-coil members, and I'm going to be on that thing. And I would encourage everybody else to take a look at that. Go to in-coil's website and get on that call, so that this is an issue. For those of you who don't know what in-coil is, it's National Conference of Insurance Legislators. I've been going 10 years. I don't think I've missed a session yet that we didn't talk about balanced billing in some form or fashion. It's an issue not only here, every state in the union. Some areas it's a bigger problem than others. Some providers, it's a bigger problem than others, and I guess the one that kind of bothers me as much as any of them is your air ambulances. For those of you who don't know, they're regulated as an airline. We have no control over them. It's a federal issue. FAA. And I've talked to my congressman about that. We need some regulation in that. Some states have absolutely no problem with that, because in some states they're all in network, in some states they're not. Young man, I've mentioned this before, passed out at Auburn, and I'm not going to say any ugly Auburn jokes, but he passed out at Auburn, and his parents got a bill in the mail for right at $100,000.
That's
Incredible. You're right. It's incredible. But I would encourage you to get on the in-coil and get in that conference call on balanced billing, because we'll have our next meeting in November, and we will be discussing it again. But anything else you'd like to add?
No, sir, I appreciate the opportunity to come here.
Thank you for coming. And here again, these folks have been great to work with. It's only the legislator who's you're tied to that I have my problems with. But no, he's great. If any of y'all want to get here about 7 o'clock in the morning, he may be in my office us talking, because we've had a couple conversations about that time in the morning. But does anybody else have any questions or comments from the audience? We have, before I let y'all leave, I wanted to let you know that we have put together a little different version of House Bill 71. We made some minor additions to it. You can stop by my office or have Pamela email it to you, or Greg had some down front also for you to pick up. There's some changes in it where I put in about, the violation of the good faith negotiation would be a unfair trade practice. We put in there about, you had to send out the bills within 90 days. These kind of things give you a chance to take a look at it. It's getting pretty close to 12 o'clock. But there's some little changes to it, primarily emphasizing the transparency part. But I would encourage you to take a look at it. We will have one, maybe probably two more meetings before session starts. But I would like to get this thing resolved so that we can have this bill ready to go before committee, maybe the first week or second week in January. Get it resolved, have the support of all the players involved so that when it hits the floor, we can get a good positive vote out of this and help our constituents who are the ones who are getting hit with these. Any other questions? Meeting's adjourned. Thank you all for coming. Have a great day. On